All right. Well, thank you all for joining another webinar that we're having this month. Recipe for a win-win relationship between CEs and contract pharmacies. Should be a very informational webinar. I'm Justin Rowland, the Vice President of National Sales for PharmaForce. So after the call, if you want to get more information on PharmaForce, please reach out to us. You'll see the information at the end on the last slide. For everyone that's a frequent attendee of these, we appreciate you coming to us every month and listening to what we have to say. We hope you find these beneficial. To everyone that's new to this, we thank you for your attendance for the first time. It's 30 minutes that Anthony Velasquez will go through and talk about the subject matter, and then we'll open it up at the end for Q&A. Anytime, please go into the box and type a question, and we'll address those at the end. And I'll pass it over to the great Anthony Velasquez.
Justin, thank you. And I want to echo what Justin said. We really are grateful for all of you that attend these webinars every month. We purposely made them 30 minutes because we know everyone's really busy with your jobs and running 340B programs and pharmacies. So we just want to thank you for attending, and our goal is that you leave out of here with value and learning something new that you didn't know before. And I don't think we're going to disappoint on this one. So again, appreciate you all joining. My name is Anthony. I am the Chief of Product at PharmaForce. I oversee all of the product development in terms of technology for the company. But the really cool thing that I have done is I've been able to serve as a 340B program manager for multiple covered entities prior to joining PharmaForce and joining the third-party administration side. So I have that blend of experience on the covered entity side and the third-party technology side that I feel gives me a perspective that I really enjoy sharing with 340B professionals on a regular basis. So let's get into the webinar topic for today. So today we're going to talk about relationships between entities and pharmacies. I want to start with a disclosure. Nothing in this presentation should be constituted as legal advice. Please do your own research, talk to your compliance teams and legal teams. On the agenda for today, we're going to talk about strategic network analysis. There is a common way that people grow their contract pharmacy network. I'm going to give you a little bit more unconventional ways that you can find volumes at different pharmacies in your area. We're going to talk about contracts and terms, cash cards, and what people are doing with cash cards, what other entities are doing with cash cards that I think is pretty interesting and innovative. We're going to talk about how including the provider is important for a successful contract pharmacy relationship. And ultimately, we're going to talk about having a reliable third-party administrator. So let's get into the topic. So first things first is you are a 340B covered entity. I was actually looking at the HRSA database the other day, and I noticed something very interesting. In the month of October alone, on October 1st, coming up, October 1st, 2023, there are a significant number of new covered entities joining the 340B program, a significant number. I want to say I saw 100 plus entities that are newly joining the program. And this discussion of how to build a contract pharmacy network is something that I think we all can learn from because it is traditionally has been done in one way, but I think there's other ways to do it that can even be more beneficial. So there's a traditional and then there's more unconventional ways to build your network. So the traditional model is you as a covered entity have to put together an MPI list, share that MPI list with your TPA, usually your TPA is usually your liaison. Then that list is sent to the gateways or sent to the pharmacies for the pharmacies and the gateways to do an analysis to see, do you have prescription volume going to those pharmacies from your providers, right? That's the traditional way. I would say 90% of the time, that is the way that network analysis are conducted, okay? The problem with that is, especially in this new world where we have a lot of referrals, referral volume, and entities are implementing referral programs, if you don't have the MPIs of the providers that you are referring to, especially in the specialty world, you could be doing an analysis that shows little to no volume, but actually, if you consider the referral perspective, there actually could be significant volume. So what I recommend doing, one of the tips that I want to give covered entities is spend a little bit of time, whether you get this data from your EMR or you get this data from other your social work team or providers, or you research it yourself in Google, is compile a list of specialty providers that you are prescribing to. Now, if you are a health system that you have your own specialist, this is not a problem for you, but primarily for health systems and covered entities where you're referring out all of your specialty volume and provide and patients. One of the things that you could do is to have sort of this backup list. So you have your main provider list, then you have a list with providers that you are referring to, and that list should be utilized when you're analyzing volume, especially in the specialty pharmacy world, because you could be turning down contracts that could actually be profitable in this traditional way. Now, some of the other unconventional ways that I think you can strategically build a contract pharmacy network is, as I mentioned, compile the referral providers, but use e-prescription reporting data. So go into your EMRs, if you have multiple, pull this from your multiple EMRs and look to see where your providers are e-prescribing. And then run a pivot table of volume per pharmacy. That data should be stored in your EMR, and then you're able to see and track a list of what pharmacies you have relationships with that are in the top 10 or top 20 of volume that your providers are prescribing to. One of the things that I've learned from the 340B space and managing contract pharmacies is it's a lot easier to capture the volume if the patient is already going there than trying to implement pharmacies and trying to educate patients and providers to go somewhere else. So you want to sort of capture the low-hanging fruit of building contract pharmacy relationships with pharmacies where your patients are already going. They are already comfortable with that pharmacy. They already have that relationship in place. Now, the other one that I think is often overlooked is, and this is, I'm guilty of this, having been the 340B program manager at a dish hospital in the past, is local pharmacies sometimes reach out to hospitals and we sometimes do not take those phone calls, sometimes don't conversate or don't build relationships with those local pharmacies, especially around your area. So I highly recommend, if you haven't done that, you're a 340B program manager, you're a program director, you're an analyst in a hospital, a health center, a grantee, to get together, work, conversate, sit at the table with your local independent contract pharmacies so that you can learn more about what services they're providing, and they can also help do an analysis for you as to how much volume from your providers are going there. I just talked to a pharmacy, just a situation with a particular entity where the pharmacy has been calling that entity for years and the entity has refused to meet with them. Don't know the reason. The point is, the pharmacy is running hundreds of thousands of dollars of prescriptions for this particular hospital. The hospital has not want to take their call or meet with them, etc. But that, I see that as opportunity being lost because of perhaps not engaging with that local independent pharmacies. I also hear of relationships where the 340B program manager meets once a month for lunch with the local pharmacy, independent pharmacy, where they have a contract pharmacy relationship. So that to say is, building a strategic network has to do a lot with also building relationships with contract pharmacies in your area. I know, I know that's something, that many entities do, but some have an opportunity to improve in that. Number two is, once you've identified the pharmacy, so let's say you did it the traditional way, which is okay, and gave a provider list to your TPA for analysis, or you're working with your independent contract pharmacy, now comes the contracts, right? And I'm not going to go into all the details or all the things that's required to be in a 340B contract, but I want to highlight a few things that I think are important for this to be a win-win for both parties. I know that there are usually a lot of discussions just around fees, but it's really not just fees. There are other parts of a 340B a pharmacy services agreement that are important and critical to a successful relationship. So what are those? Number one, compliance. Make sure that that pharmacy is a pharmacy that will be conducting business compliantly and abiding by rules and regulations. I think there have been, at least in areas that I've worked in, some pharmacies that would not, conduct themselves ethically and in ways that we as a covered entity, when I worked on a covered entity side, consider that. But that's something that you want to consider, is that there's a compliance there, and just in general pharmacy services terms. The fee structure, that there's a win-win, that there is an equitable fee structure that is fair to the covered entity and is fair to the contract pharmacy. If one feels like they got the other, that could be a recipe for a bad relationship. But there should be fairness in that. There should be an agreement on the replenishment model. And this is really important when it comes to choosing a TPA partner, of what replenishment model are you going to do? Are you going to go with a pay on dispense model, where the pharmacy is filling the medication, the pharmacy is out of the inventory for that medication, the pharmacy is not replenished immediately for that medication because it might not have reached the package size, and ultimately the pharmacy may not get paid by the PBM for 45 to 60 days. So the pharmacy is out in several ways in that model. So one of the things that I recommend, that I think is really good, is a pay on replenishment model, where I think it's a more fair balance in that contract relationship. Historically, the pay on dispense model was sort of the main model in the 340B space, but with time, I've seen a lot more contracts move to a pay on replenishment model. I have been part of some conversations where we have saved relationships because the pay on replenishment model was more beneficial to the covered entity, and they felt it was more fair. Your wholesaler selection. Some contract pharmacies might say, no, I want you to use the wholesaler that I'm buying. Some entities might feel a different way. So you want to make sure that you clear that up. True ups. Does your program involve true ups? This usually is determined by what replenishment model you go with, but you want to select a true up timeframe reconciliation. If you are with a TPA that does true ups and a pay on dispense model, that is fair to both parties. Now, is that 90 days? Is that 180 days? Is that a year? That's totally up to you, and that's negotiable between the covered entity and the pharmacy, and you have to find what works for you. But that is something that you want to discuss upfront before starting your relationship. Whether you're going to do a winners only, this is something that's also important. Are you going to do only capture claims that are profitable? Are you going to do brand and generics, or brand only, or brand and generics but winners only? And as it relates to generics, so that's also another conversation that you want to have with your contract pharmacy. And payment terms. This is a big one. I've actually seen this a lot in my time in 340B, where there are payment disputes between covered entities and contract pharmacy. So this is something that you want to address up front. Make sure that you have a proper payment term model that aligns with the contract pharmacy's ability to pay the covered entity in time, especially when you're dealing with a lot of specialty drugs and there's going to be big dollars changing hands. That is something that you want to discuss thoroughly. All right, moving to number 3 in the recipe for a win-win relationship is innovative cash card programs. This is something that you want to talk with your contract pharmacy is, hey, are you willing to do a cash card program? We want to help our patients. We want to help the communities. I would say for the most part, some contract pharmacies are all in, especially independents. Yes, we we want to help the community as well, and this is usually not a problem, and usually allowed in that case. And your gateway relationships, when you're dealing with big players and big gateways in the industry, this is something that's not always an option. So if you're strategically building a network and this is something that you and your entity would like to offer, you want to consider that as you're selecting the pharmacy partners that you're going to build your network around. But considering true ups, again, in this situation is super important. Think about manufacturer restrictions as well. A lot of entities are adjusting their cash card programs to ensure that they're adjusting the formulary so that patients are getting the discounts at the selected store, for example, where the 340B pricing is offered. Please know, if you are offering a cash card at all of your contract pharmacies and your patients are getting that 340B pricing and they're paying very little for their medications, that medication may be replenishing at a non-340B pricing, and it could be costing you a lot of money. So you want to consider that as you're establishing this cash card program. One of the other things that I've seen that's very interesting in this space is entities using a cash card like program for their employees as well, where their employees can go to a designated pharmacy, or there's certainly you want to consider talking to your compliance and legal team about this, but entities that are figuring out ways to incentivize patients and employees to utilize their designated pharmacy in cases where the manufacturer allows you to select one contract pharmacy where the 340B pricing is offered. So you want to discuss that with your team and your third-party administrator about their capabilities to support that. But I have seen that being something that more and more entities are doing in order to get more patients that are uninsured or underinsured their 340B medications. All right, next we have, and this is what I think, this is the one that I'm most excited about, because this is the one where I sort of, as I was running a 340B program, learned that this was a interesting hack in improving a contract pharmacy relationship. But fostering a provider pharmacy collaboration is huge. There are many instances where the contract pharmacy is local, sometimes right next door to the covered entity, and they would like to meet with the providers. And I know that entities have different policies for that, but meeting with that provider, doing provider education, involving the provider and helping them understand why the 340B program is important could be huge for increasing your 340B capture rate at a particular strategic contract pharmacy. Establishing a closer relationship between the provider and pharmacies, I think is healthy, and I think is good. I worked at a dish hospital where we did that with some of our specialty practices, where we would allow our contract pharmacy, our specialty pharmacy liaison to come in, meet the office manager, meet the provider, make sure that there was a direct line of communication in case anything went wrong with a patient's prescription. And that ultimately led to higher prescription being sent to that specialty pharmacy and being captured at 340B. There was another time where I think my intention was to establish a contract pharmacy relationship with a specialty pharmacy that I liked, but the providers had sent all their scripts to another specialty pharmacy that was not in our network, and the providers would not change their prescribing behavior and just really enjoy working with that one specialty pharmacy. So this is why I think this is important, that as you, as a 340B program manager, you're having these conversations with your specialty practices or your primary care physicians, and knowing where they like sending prescriptions could be something that uncovers information that you didn't know before. For me, in this situation, it was that the specialty provider was a gastroenterologist specialist, loved sending prescriptions to this one pharmacy, never had an issue sending prescriptions to that one specialty pharmacy, felt that her patients got great service. I went and got a contract pharmacy relationship with another specialty pharmacy, and it just never worked. and we weren't able to build that. So I'm sharing that with you all on this call because I think that this could be a great way that you can potentially build up your contract pharmacy network, especially around specialty prescribing. All right, next. So let's say that you did everything. You put everything into the recipe of building a win-win relationship between your covered entity and your contract pharmacies, right? So you identify the pharmacies, right, that you need to in order to build your contract pharmacy network. You have a good contract in place, a fair contract. You negotiate a great deal for your covered entity. You got your contract pharmacy to say, yes, we want to do a cash card program and we want to help the community. You have good relationships with your providers where you are educating the providers. The providers are involved in the 340B process. They know what 340B is. They know, what contract pharmacies are part of your network, right? So you have all of this in place, right? But if you don't select the right third-party administrator, you could end up having a failed relationship. So this is where this is really crucial, that you are working with a third-party administrator that can help you, number one, maximize your capture rate. Number two, avoid unreconciled true-ups. Again, I enjoy sharing these webinars because I can share real stories that I come across on a regular basis, whether in my past as being a 340B program manager or in my current role, working with thousands of entity pharmacy relationships on a regular basis, where I have seen a pharmacy shut down, a relationship shut down because of low capture rates. But then when a new third-party administrator introduced, that capture rate goes up because the logic was better and more improved. I have seen relationships where the contract pharmacy didn't know that they had all this amount of claims that they had dispensed as cash cards and never got trued up. And now they're upset because they have now lost a significant amount of money, and there's a dispute between the entity and the contract pharmacy, and it was related to perhaps involved because of a third-party administrator issue. I have seen situations where entities and pharmacies don't trust the invoices that are being generated by their third-party administrator. You name it, I've seen it. So that's why this is really important, that in order to sort of, build this win-win relationship, that covered entities who usually have the say and usually are the ones deciding what third-party administrators to use, that you are making the right decision and picking a third-party administrator that aligns with your program goals, what you are hoping to achieve, how your contract is structured, that TPA can support the dispensing fees that you have in your contract, the replenishment model that you have in your contract, etc. A lot of that is usually vetted through the TPAs, and usually you're building this network along with your TPA. So hopefully a lot of that is taken care of. But you want to make sure you are choosing a third-party administrator that is going to help you and be a thought partner with you as you manage your 340B program. I don't even have to go into managing other things like manufacturer restrictions and all these other things that have come up in the 340B program recently that are challenges that entities are dealing with, because those are just, additional things that you want to have a good partner for. But for executing on a good win-win relationship where both parties feel they have a fair contract in place, and that the data is trustworthy, that the 340B administrator is reliable, that the data is accurate, that the financials are reconciled in a timely basis, it is critical for you to choose the correct third-party administrator, or you could end up being in a failed relationship. And it does happen. So with that being said, thank you so much for joining today. Ending a little bit early, but as always, we love to do Q&As at the end. So I see there's a few questions in our Q&A. I would love to unmute anyone that would love to ask a question and we can have a discussion and a conversation. So if you have a question that you want to ask, please raise your hand in the Zoom chat, and I will allow you to talk by hitting the Zoom button, allow you to talk, and then we're able to have a conversation about your particular question.